Good afternoon and welcome to this quick revision session from Dermatology. In this session, we will be basically discussing 100 one-liners in dermatology. So it's like a quick recap. So I would want this session to be very, very interactive and I would want answers from you because obviously there's no theory here. I would just ask you one-liner questions and I would want you to answer them so that we can discuss. And if there is anything related to that that you would want to know, I'll be willing to answer those. So let's get started. Before we start, I would want to know whether you are able to hear me, whether you can see me. And so we move on. Hello, students. So yes, obviously the questions which have been covered here are from high yield topics only, and they're basically one-liners which have been asked in the previous year exams or which are related to what has been asked. Great. So let's get started. So these are the three first one-liners. Now I have put three so that it's easier to discuss. So you can give me answer to each one of them. And once you give me your answers, then we'll discuss. So my first question is layer of skin which is underdeveloped in low birth weight neonates is. So, which is the layer of skin which is underdeveloped in low birth weight neonates? So, I would request that if there are any other questions which is not pertaining per se to the session, we can discuss them later because it kind of breaks the flow for other students and for me. So, we'll kind of restrict to what we are discussing right now. Okay. So perfect. So you all know that it is the stratum corneum which is underdeveloped in low birth weight infants. And this is because my skin development, my epidermis development happened from stratum basale, then upwards to stratum corneum. So if a neonate is born premature, the topmost layer of the skin, which is stratum corneum, will be underdeveloped. And you should be knowing that. So next question is a very good, you all know answer to this. Fox-Fordyce disease is a disease of. So basically, I want to ask, it is a disease of which gland? Fox-Fordyce disease is a disease of which gland? Yes, you're right, sweat glands, but there are different kinds of sweat glands. I am predominantly asking which particular type of sweat gland is involved, and that leads to Fox-Fordyce disease. Okay, right. So here comes the confusion. So I'll clarify. Fox-Fordyce disease is a disease of apocrine gland. Now, a lot of you get confused between Fox-Fordyce disease and Fordyce spots. So Fordyce spots are a disease of sebaceous glands. Fordyce spots are basically what you see on lips. They are ectopic sebaceous gland which are present in the oral mucosa or on lips. That is Fordyce spots and that is a disorder of sebaceous gland. Fox-Fordyce disease is something that you see in pubertal females. On their axilla, there are small whitish papules which are present, and that is Fox-Fordyce disease, and it is a disorder of a sweat gland, predominantly apocrine gland. Clear? So there should be no confusion here. Fox-Fordyce disease, apocrine gland, Fordyce spots, sebaceous gland, right? So don't get confused. Fordyce spots. Spots is something that you see here. Fox-Fordyce disease is apocrine gland. It is there in prepubertal females present in the axilla as monomorphic papules which are asymptomatic. Clear? Great. So let's move on to our third question, which is Langerhans cells are present in which layer of the skin? Also, can you tell me what granules are present in Langerhans cells? So I've made it two questions. Yes, they are present in stratum spinosum. So quickly revising, there are four main types of cells. So keratinocytes, which are present in all skin layers, melanocytes, and Merkel cells, which are present only in stratum basale. This is present in all cell layers. And Langerhans cells are present in stratum spinosum. Langerhans cells, okay, what granules are you giving me? I asked you Langerhans cells have what granules? LED granules are granules that you see in stratum lucidum. They are refractile granules which are present in stratum lucidum, which is a layer of epidermis present only in palms and soles. Here I am talking about the granules that you see in Langerhans cells. They're called as Birbeck granules. Absolutely right. So Birbeck granules or racket-shaped granules are present in Langerhans cells. Langerhans cells are present in stratum spinosum. These are antigen-presenting cells which are derived from mesenchyme. They have Birbeck's granules, which are racket-shaped granules, and they mainly work as antigen-presenting cell, and they are a type of dendritic cell. So this is all the information that you need to know about Langerhans cells. There are 4 cells in the epidermis, keratinocytes present in all cell layers, Merkel cells and melanocytes present in stratum basale, and Langerhans present in stratum spinosum. Clear? Any confusion with this? So we'll quickly revise the simultaneous topics also. So moving on to the next set of questions. Which type of hypersensitivity reaction is patch test? Which type of hypersensitivity reaction is patch test? Great. So yes, it is a type 4 hypersensitivity reaction. When do you read a patch test? Next question, quickly. When do you read a patch test? What is the best time to read a patch test? So type 4 hypersensitivity was easy. I see that all of you know that, so not touching upon that. What is the best time to read a patch test? Very good, yes. So if I have to give you one answer, it would be 96 hours. Though the best answer would be 48 hours and 96 hours. But if it is not there in the option, you will mark 96 hours as the best time to read a patch test so that you can look at delayed reactors also. Patch test is a test which is done to identify the allergens in contact allergic dermatitis. It is done on back of a patient and it is a type 4 hypersensitivity reaction. So if you have to give one best answer, it should be 96 hours. However, if in the question they've mentioned 48 and 96 hours, then you would give this as answer. Here, it would not be 48 hours if 96 hours is there in the option. Most commonly, we read it at 48 hours, but we can miss delayed reactors if we do not reread the patch test at 96 hours. Clear? Next question. Slap cheek appearance is seen in. Where do you see slap cheek appearance? Very good. Parvovirus infection, parvovirus B19. What is the infection called as? Great. So yes, slap cheek appearance is something, it's a viral infection caused by parvovirus B19. It is also called as erythema infectiosum. So erythema is redness, infectiosum is something that's spreading. So a child who's otherwise well presents with turgid erythema on the cheeks, it looks like somebody has slapped the cheek of the child, and that is why it's called as slap cheek appearance, right? Great. Next question. Swimming pool granuloma is caused by? What is swimming pool granuloma caused by? Great, you all know everything. So yes, swimming pool granuloma is caused by Mycobacterium marinum. It is a type of atypical mycobacterial infection which is usually seen in wetlands and it is called as swimming pool granuloma. Great. So this is what you need to know about swimming pool granuloma, that it is caused by atypical mycobacterial infection called as Mycobacterium marinum. Great. So let's move on to the next set of questions. Bocard's impetigo refers to. What is Bocard's impetigo? Bocard's impetigo refers to? Quickly, at least give me some answers. You may be wrong, that's okay, but at least try. Okay, good. So it is a type of bacterial infection. Very good. Is it a type of impetigo? Okay, tell me that. Is Bocard's impetigo actually an impetigo? Good, you're coming closer. Yes, Bocard's impetigo is caused by Staphylococcus aureus. Yes, it is not a type of impetigo. It is a misnomer. It is actually referred to superficial folliculitis caused by Staph aureus. So, when we talk about folliculitis, there is superficial folliculitis and there is deep folliculitis. So, Bocard's impetigo is a misnomer. It refers to superficial folliculitis, which is caused usually by Staphylococcus aureus. Right? So it is, that's why I have put in here, don't confuse it. It's not a type of bullous impetigo or it is not a type of impetigo contagiosum. These all questions have been asked previously in the exam. Right, it is superficial folliculitis. Moving on to the next question. Urticaria, which happens on exercising and sun exposure, is called as, so what is the form of urticaria? Or what is that urticaria called, which happens on exercising and sun exposure? That means when the core body temperature is increasing. Yes, this is called as cholinergic urticaria. So cholinergic urticaria is a type of chronic urticaria which happens on exercising and sun exposure, because in that there is increase in core body temperature leading to increase in cholinergic secretions, leading to something which we call as cholinergic urticaria. Right? Great. Next question. Syringoma is a benign growth of which structure? So when a patient has syringoma, it's a benign growth. But what part of skin does it involve, or what structure of skin is involved when we call it as syringoma? Good. Okay. So quite clear. Yes, it is eccrine sweat gland. Can you tell me which part of eccrine sweat gland is responsible for syringoma? It basically is because of involvement of acrosyringium of eccrine sweat gland. So, but you are absolutely right. It is a benign growth structure of eccrine sweat gland. So, syringoma is a type of benign tumor which is caused by involvement of eccrine sweat glands. It is predominantly located around the eyes, and they appear as very small fluid filled lesions which have, if you rupture them, there is watery secretion and they are predominantly present in the periorbital area. If you do a histopathology from syringoma, you see a particular kind of cells. What are they called as? If you do a histopathology from syringoma, what cells do you see? Yes, you're all right. Eyelid margin, eccrine gland, this is all correct. Okay, I'll tell you. So, if you do a histopathology, you typically see tadpole or comma-shaped cells. Tadpole or comma-shaped cells. Okay? Right. Next question. Heliotrope rash is a feature of. Heliotrope rash is seen in which condition? Okay, great. So this is, I think, clear. Can you tell me? Yes, Dr. Shivanshu, right? Can you tell me that what are the pathognomic lesions in dermatomyositis? So yes, heliotrope rash is a feature of dermatomyositis. My next question is, what are the pathognomic skin features of dermatomyositis? Heliotrope rash is a kind of confluent macular violaceous erythema that you see around the eyes in patients of dermatomyositis. But heliotrope rash is not a pathognomic feature of dermatomyositis. It is a characteristic feature, but not pathognomic. So yes, you're all right. So pathognomic feature for dermatomyositis is Gottron's papules and Gottron's sign. Right? So please remember, if in the question they ask you the characteristic, the pathognomic feature of dermatomyositis, and in that heliotrope rash and Gottron's papular sign is both given, please mark Gottron's papular sign because that is more pathognomic. Right? Great. Moving on to the next question. Papillary microabscesses are a feature of, where do you see papillary microabscesses on histopathology? So this is a histopath feature of, yes, you're right, Holster sign is also seen in DM, but again, it's not a pathognomic feature. Okay. So please look at the question again. It is not, it's something else. It's papillary microabscesses. It is not Potterier's microabscesses. So that's where you're making a mistake. Yes, yes, you're right. This is seen in papillary microabscesses are a feature of Dermatitis herpetiformis. So few of you are answering mycosis fungoides. So please remember, Potterier's microabscesses is seen in mycosis fungoides. Papillary microabscesses are a feature of Dermatitis herpetiformis. Dermatitis herpetiformis, you all know, will present with enteropathy and with itchy lesions in the extensors. It is very difficult to diagnose clinically. You do a biopsy, you see papillary microabscesses, you do DIF, you again see IgA deposition in the papillary microtips. Yes, you're right. This is also referred to as papillary tip microabscesses. And yes, the infiltrate here is mainly neutrophilic. In mycosis fungoides, the infiltrate is lymphocytic. It is T lymphocytes, and that's called as Potterier's microabscesses. But papillary tip microabscesses or papillary microabscesses are a feature of Dermatitis herpetiformis. Clear? Yes, treatment is Dapsone, and very, very important in treatment, gluten-free diet. You have to go for gluten-free diet and Dapsone both, right? Next question from the basics. Acanthosis involves which layer of the skin? What is acanthosis and what layer of the skin does it involve? Yes. So acanthosis is increased thickness of stratum spinosum. Increased thickness of stratum spinosum is called as acanthosis, and you see it in chronic eczemas. Now, don't confuse acanthosis with acantholysis. Acantholysis is something that you see in Pemphigus group of disorder where there is separation of keratinocytes. Acanthosis is increased thickness of stratum corneum, which you see in chronic eczemas. Clear? Great. Next question. Cutaneous tuberculosis, which is caused by contiguous spread from an underlying foci of infection, is called as. So if there is an underlying foci of infection and from there is contiguous spread into the skin, what is that kind of cutaneous tuberculosis called as? Good, Dr. Chaitanya. No, no, no. So don't get confused. By contiguous spread, we call it as scrofuloderma. So I'll quickly revise cutaneous TB for you. Cutaneous TB has different forms. If it is exogenous source, and happening for the first time in patients who are not immune, I call it TB chancre. If it is happening in individuals who are already immunized to MTB, we call it TBVC, right? Endogenous forms of cutaneous TB depends on, endogenous means there is a source of infection. So TBVC, which you were saying, it is not by endogenous source. TBVC is a verrucous plaque that you see on exposed areas. Whereas if there is an endogenous source of TB, it may spread by contiguous route, when I call it scrofulloderma. It may spread by auto-inoculation, or it may spread by hematogenous route. Auto-inoculation is orificial tuberculosis, contiguous spread is scrofulloderma, and lupus vulgaris is predominantly hematogenous spread, right? Tuberculins are a type of hypersensitivity reaction. They are type 4 hypersensitivity reaction to some MTB antigen or bacilli which is there in the skin. Clear? So please don't get confused. If they say what is usually an underlying foci here, it is usually a lymph node. It can be a bone, it can become a lacrimal gland, but the most common area is this cervical lymph nodes. So when there is cervical lymph node TB that the patient has, gradually that lymph node gets enlarged, it touches the skin and spreads the MTB from the lymph node to the skin. This is called as contiguous spread, and there is an underlying foci, which was my cervical lymph node. So scrofulloderma is through contiguous spread. Lupus vulgaris has multiple modes of spreading. The most common that you should be knowing is hematogenous spread, right? It can also spread through auto-inoculation and other ways, but for you, the most important spread for lupus vulgaris is hematogenous spread. Clear? And the most common underlying foci is cervical lymph node. So if they want to give you in the exam, they'll usually give you this area. Right? So should we move on to the next question? FDA approved therapies for androgenetic alopecia includes. So what is the FDA approved therapy for androgenetic alopecia? Yes, it is minoxidil, which is approved by FDA for androgenetic alopecia. And you use 2% minoxidil for females and you use 5% minoxidil for males. Yes, absolutely right. Even finasteride is FDA approved. Finasteride is DH2 blocker, and both minoxidil and finasteride are approved by FDA for androgenetic alopecia. Clear? Great. Feature on Zang smear of herpes genitalis patient, but not in a patient of pemphigus is, so when you do a Zang smear, on Zang smear, how do you differentiate herpes genitalis from pemphigus? You do Zang smear for both of these patients. How do you differentiate? Yes, finasteride is 5-alpha inhibitor. Both minoxidil and finasteride are FDA approved. Great. Yes, Dr. Chaitanya, you are right. So both in herpes and in pemphigus, you would see acantholytic cells on Zang smear. So this will be seen in both the conditions. But in herpes, you would see multinucleate giant cells, which is not seen in pemphigus group of disorders. So multinucleate giant cells help to differentiate a herpes patient from pemphigus patient on Zang smear. So to say MNGs are a feature of herpes infection, not pemphigus group of patient. Right? Yes, this is multinucleate giant cells are caused by cytopathic effect of HSV on the keratinocytes. So you see both acantholytic cells and MNGs, but MNGs are what you see in herpes and you do not see it in pemphigus group. Clear? Okay. Pterygium of nails is a specific feature of what condition? In which condition do you see pterygium? No, you do not see any giant cells in pemphigus. In pemphigus, you see giant cells, which are also called as acantholytic cells. You do not see giant cells in pemphigus. Great. Okay, so pterygium of nails, Dr. Pihu, you are right, is a specific feature of lichen planus. What is pterygium? Pterygium is wing-shaped extension of proximal nail fold on the nail plate. And this is seen with lichen planus. With lichen planus, the most common finding that you see is longitudinal ridging. But this is the most common finding. Most specific finding for lichen planus is pterygium of nails. And also I'll discuss psoriasis here. So in psoriasis, the most common finding that you see are pits. But the most specific finding for nail psoriasis is oil drop sign or salmon patch, right? Yes, very good. So it's not fungal infection. You do not see pterygium in fungal infection. For psoriasis, specific sign is oil drop sign. For lichen planus, it is pterygium. Right. Moving on to the next question, an epidermal nevus which appears during adolescence is called as, which is the epidermal nevus? Usually nevus would appear at birth or near birth, but which is that kind of epidermal nevus which appears during adolescence? Quickly, epidermal nevus which appears during adolescence. At least try to give some answers. Yes, absolutely. It is Becker's nevus. So Becker's nevus is an epidermal nevus, but the characteristic feature of Becker's nevus is it would appear during adolescence, and that is how you diagnose Becker's nevus. So usually you'd have an adolescent individual coming to you with some hyperpigmented lesions on one side of the body, and they will say that it just appeared. So Becker's nevus is something which will appear in adolescent. It is usually associated with hypertrichosis. So there is a hyperpigmented patch with overlying hypertrichosis, right? So nevus of Ota or Ito are not epidermal nevus. They are dermal nevus. Please remember, Mongolian spot, nevus of Ota, nevus of Ito. They are all dermal melanocytic nevi. That's why they appear blue because of Tyndall effect. Becker's nevus is a type of epidermal nevus and it appears during adolescence, right? This is the most important giveaway point for Becker's, that it appears during adolescence, right? The next question is something which we have already discussed. The classical histopath feature of mycosis fungoides is, so there you will talk about Pottrier's microabscesses, right? So Pottrier's microabscesses is the classical histopath feature of mycosis fungoides. This we have already discussed. So please don't say papillary microabscesses now. So it's Pottrier's, right? So Pottrier's is mycosis, papillary is dermatitis herpetiformis. Clear? Drug of choice for type 1 lepra reaction. Quite easy question, I think. What is the drug of choice for type 1 lepra reaction? So till then, I'll quickly revise type 1 lepra reaction with you. Type 1 lepra reaction is a type of type 4 hypersensitivity reaction. You see it in upper spectrum. Here, the existing lesions, they become more erythematous, tender, and edematous, and there is nerve involvement in the form of nerve abscess, nerve pain. It is usually happens after you start a patient of leprosy, of upper spectrum of leprosy. You start MBMDT and this reaction happens. Why are you guys saying Dapsone? I don't understand. It is steroid, type 1 reaction or type 2 reaction. This is just to confuse. Drug of choice for both type 1 and type 2 lepra reaction is steroids. So this was not leprosy. I was talking about lepra reaction. So dapsone is a part of MBMDT. You would continue MBMDT. So for both kind of reactions, you continue your multi-drug therapy and you give steroids. So drug of choice is steroids. Milder reaction you can manage with NSAID, but if they ask you drug of choice, it is steroids. Please don't get confused here. Yes, it is a type 4 hypersensitivity reaction. Type 1 lepra reaction, type 4 hypersensitivity, type 2 is type 3 hypersensitivity. Remember, drug of choice for both of them is steroids and continue MDT or start MDT if the patient is not on MDT. Clear? So I hope there's no confusion here. Great. Bullous pemphigoid in pregnant female is called as, what is it called as? Quickly, this is an easy one. Okay. Taxi? What is taxi? Okay. So not pemphigus, but pemphigoid gestationis. So it is pemphigoid gestationis. It is nothing but bullous pemphigoid in pregnancy. Typically, you will have lesions in the periumbilical area. It can also happen in individuals with trophoblastic tumors. And a very, very characteristic feature here is that you see C3 deposits on DIF. So in 100% of cases, you would see C3 deposits on DIF here. So it is pemphigoid gestationis. Okay, that's okay. And not pemphigus gestationis. I can understand autocorrect. Yes, it is subepidermal disorder. Great. Next question, cause of bindi dermatitis in females is, I'll be a little quicker. We are half hour done and we've not covered half of the questions. So now I'll be quick. Cause of bindi dermatitis in females. Quickly, yes. The easy one, it is para-tertiary butyl phenol. For hair dye, it is paraphenylene diamine. Okay, so bindi dermatitis is caused by PTBP. You all know that. So the best way to diagnose atopic dermatitis is. We'll quickly move on to the next question now. The best way to diagnose atopic dermatitis. You can also tell me answers to all these three together if you want to. So best way to diagnose atopic dermatitis is, yes. And if no, not patch test, you do not do patch test in atopic dermatitis. You diagnose it by clinical method. So there is no test to diagnose atopic dermatitis. So best way to diagnose is clinical, and you use your Hanifin and Radka criteria. You might see a high IgE, but that's not a diagnostic test. So atopic dermatitis is diagnosed clinically, right? No, not IgE, no patch test, clinical diagnosis. Next question, treatment of choice for genital warts in pregnancy. A pregnant female with genital warts, what will you do? Quickly. Good, yes. Cryotherapy is my treatment of choice. We can also do trichloroacetic acid. So both these answers are correct. You do not give metronidazole, please. Metronidazole is for bacterial vaginosis. For genital warts, you do cryotherapy and TCA in pregnant patients. Okay, this is an important question. Malignant pustule is a feature of, where do you see malignant pustule? Hmm. Are you guys looking for answers somewhere? Or is it the lag between me asking and you replying? I guess yes. So malignant pustule is a feature of bacterial infection called as anthrax, which is caused by Bacillus anthracis. It is a zoonotic infection Nothing about this lesion is malignant, neither it is a pustule, but it is called malignant pustule because it does not look good. So anthrax, the classical feature of anthrax is malignant pustule, and it is caused by a bacilli called as Bacillus anthracis, not TB. Please don't mark TB. It is anthrax and caused by Bacillus anthracis, right? X-linked recessive ichthyosis is caused by. So where is the defect in XLRI? So the defect in XLRI is, yes, there is a scab which is present in malignant pustule. You're right. X-linked recessive ichthyosis is something which will manifest in usually males. It happens usually later, does not manifest during birth, and typically you see very dirty looking scales in the preauricular area, on the neck, on flexures. But what is the defect here? So the defect is in steroid sulfatase gene, also called as STS gene. So defect in ichthyosis vulgaris is there is a defect in filaggrin. In lamellar ichthyosis, the defect is in transglutaminase, and in X-linked recessive ichthyosis, the defect is in steroid sulfatase gene. Clear? Yes, you're right. So I'll move on to the next question. Moth-eaten alopecia is seen in. Moth-eaten alopecia is a feature of, and also answer the next question. We have to quickly do it so that we can cover maximum questions. Also tell me, Max Joseph space is a histological finding which is seen in what condition? Oh, okay, good. Not alopecia areata. It is a feature of secondary syphilis. Moth-eaten alopecia presents with patchy alopecia, non-cicatricial, and is a feature of secondary syphilis. It is not a feature of alopecia areata. It is not a feature of SLE. With SLE, you see lupus here. With alopecia areata, you see patchy alopecia, but it's not moth-eaten. Okay, so moth-eaten we say for syphilis. Max Joseph space is a histological finding that you see in lichen planus. This is correct. What is Max Joseph space? In between epidermis and dermis, there is a little space that forms because of dense lymphocytic infiltrate, which is there in the dermis, which pulls the dermis down. So there is a little empty space that you see on histopathology between epidermis and dermis, and that is called as Max Joseph space, and that is seen in lichen planus. Okay. Yes, you also see severed bodies or apoptotic keratinocytes here. And very importantly, you see hypergranulosis here, which is wedge-shaped hypergranulosis. Clear? Next question. Leash nodules are a feature of which? In which condition do you see leash nodules? NF1, yes. So leash nodules are something that you see in iris. They are a feature of neurofibromatosis 1. It is a type of genodermatosis, and leash nodules are an important feature of that. Next question. Scabies in infants differ from adults because it involves what site? Yes, so leash nodules, you're right, are iris hematomas. They are benign. You can have buttonhole sign. Buttonhole sign is not with leash nodules, it's with neurofibromas, but you're correct about it. Yes, scabies in infants differs from adults because it involves face. In adults, you do not see face involvement because of the presence of sebum, which is multicidal, whereas in infants, you see face involvement. Also, in infants, you see vesicles, which you usually would not see in an adult because adult scratches and breaks those vesicles, right? Great. Circle of Febra and all you know. STD, which is caused by a protozoa, which is an STD, which is caused by a protozoa. Very good. So you all know this. It's Trichomonas vaginalis, and Trichomonas vaginalis is an important cause of vaginal discharge, and it is caused by a protozoa. And so if you look at, if you make a smear, you see these motile perky bodies, which are nothing but flagellate protozoa. Trichomonas vaginalis leads to greenish frothy vaginal discharge. And it also leads to strawberry cervix. Please remember that. Next, disc keratosis is the feature of which benign dermatosis? Yes, strawberry cervix I mentioned. Yes. Trichomonas, yes, both partner treatment is needed. It is only bacterial vaginosis where you do not need partner treatment, because that happens not because of infection, but because of altered microflora. Great. Moving on to the next question. Disc keratosis is a feature of which benign dermatosis? Disc keratosis is abnormal keratinization. You see abnormal keratinocytes. It can be seen in certain benign conditions, can also be seen in malignant conditions. So you need to tell me benign dermatosis where you see disc keratosis. Absolutely right. One is Darier's disease. Which is the other one? One is Darier's. Which is the other one? So, Dr. Chaitanya, you're right. You see it in cervical cancer, but I'm talking about skin conditions here. In malignant ones, you see it with BCC, you see it with SCC, you see it with Paget's disease. Benign, Darier's and Haley-Haley. Darier's and Haley-Haley are two inherited acantholytic disorders where you see disc keratosis. So disc keratosis is seen with both Darier's and Haley-Haley. These are benign conditions. Malignant conditions presenting with disc keratosis is BSP, which is basal cell, SCC, and Paget's. Right. Most common cause of recurrent scaly hypopigmented patches on face in children is what causes recurrent scaly hypopigmented patches on face of a child? Quickly. I'll give you a hint. It's usually seen in atopic children. There are multiple lesions. They're recurrent, they're scaly, they're hypopigmented. Okay, so intermittent leprosy, which is a close DD of this condition, is not the answer here. Intermittent, I think you mean indeterminate leprosy. I'm also saying indeterminate. So indeterminate leprosy will not be recurrent. It will not be scaly, right? Yes, it is pityriasis alba. Pityriasis alba is a type of silent eczema presenting in children with the recurrent scaly hypopigmented patches. So it's usually seen in atopic. Its close DD is indeterminate Hansen, and indeterminate Hansen is usually seen in endemic areas. It will not be recurrent. There will usually not be multiple patches, and it is not scaly. Pityriasis alba, if you do a biopsy, you'd see spongiosis because it's a type of eczema. Okay, so I hope it's clear now. Next question is quite easy. Row of tombstone appearance in histopathology is seen in. Where do you see row of tombstone appearance? Yeah, this is quite easy, I think. It is seen in Pemphigus vulgaris. So Pemphigus vulgaris involves the basal layer. They are separated and they appear like row of tombstone appearance. Next question. Most sensitive index to assess the effectiveness of a drug or its resistance in skin smears in leprosy patients. So if you have a leprosy patient and you want to assess drug effectiveness or drug resistance in skin smears, what index will you utilize? So here you would utilize morphological index. So there are two types of index, bacteriological index and morphological index. In morphological index, you look for solid staining bacilli. So this is an index which tells you about drug resistance or drug effectiveness. Whereas bacteriological index, which is more commonly done, will not tell you because there you count both solid and fragmented bacilli. You count both live and dead bacilli. Whereas morphological index is something where you only count live bacilli. So this can tell you about drug effectiveness and resistance. Clear? Next question. Footprints and snow appearance is a feature of MI? Yes, you see only viable bacilli. So if you see viable bacilli, you know that the drug is not responding, right? If you count both dead and live bacilli, you'll not be able to find out whether the drug is effective or not. So BI counts both dead and live bacilli, whereas morphological index only counts live bacilli. Yes, so this is the easy. Footprints and snow appearance is seen with pseudopelade of Brock. It is a type of cicatricial alopecia, which is idiopathic. You do not know what the cause is. Next question. The type of psoriasis which responds to antibiotics. Which type of psoriasis responds to antibiotics? So this is a type of psoriasis that you see usually in children. Yes, this is guttate psoriasis. Guttate psoriasis is usually preceded by a streptococcal infection. You see it in children. You see raindrop-like appearance. And this is one psoriasis where you give antibiotics. Great. Next question. Higgs-Menache's sign is seen in. Where do you see Higgs-Menache's sign? Answer all the three questions. That will be quicker. Higgs-Menache's sign is seen in intraepidermal immunobullous disorders caused by formation of antibodies against what? And where do you see target lesions? So three questions, quickly answer them all. So Higgs-Menache's sign, you are right, is seen in syphilis. What particular type of syphilis you see it in? You see it in congenital syphilis. And especially it is a type of stigma. So you see it in late congenital syphilis. Higgs-Menache's sign is thickening of this clavicular end. So clavicle thickening is called as Higgs-Menache's sign seen with congenital syphilis. Next question. Intraepidermal immunobullous disorders are caused by formation of antibodies against what skin structure? So not desmoglein 1 in specific, desmoglein. It can be 1, 3, or other parts of desmoglein. So usually they are caused by antibodies against desmoglein. Next, target lesions are seen in. Where do you see target lesions? You're right. Target lesions are a feature of erythema multiforme, which is caused 90% of cases by after a viral infection, but can also be caused by drugs. EM typically has target lesions. Which genital ulcer disease does not involve lymph nodes? First question. Second, erythema chronica migrans is a feature of what disease? And what is the most common endocrine disorder that you see associated with vitiligo? LGV is one which only involves the lymph node. In LGV, you see predominantly lymph node involvement. You do not even see an ulcer. So it's not involved. I'm saying which does not involve lymph node. Groove sign is true for LGV because LGV involves lymph node. I'm saying which genital ulcer disease does not involve lymph nodes. So this is donovenosis. In donovenosis, you do not see involvement of lymph nodes. You see pseudobugose, which is appearance of genital ulcer on lymph nodes. But donovenosis does not involve lymph nodes. Yes. ECM is a feature of Lyme's disease. Absolutely right. Lyme's disease caused by spirochete, Borrelia burgdorferi, the vector being isodid ticks. ECM is a feature of Lyme's disease. And the most common endocrine disorder seen associated with vitiligo is, you're right, it is thyroid disorder and predominantly Hashimoto's thyroiditis. Right? Here, so I think this is something which you should be knowing. And I think most of you could not answer this. Genital disease not involving lymph nodes is donovanosis. Hashimoto's is right, not diabetes, but it is Hashimoto's disease. Next question. Annular herald patch is a feature of the most common cause of contact allergic dermatitis and which is the rarest variety of pemphigus. Where do you see herald patch? Yes, herald patch is a feature of Pityriasis rosea. Pityriasis rosea presents with the first patch, herald patch, which is called the mother patch, which is larger, and then it presents with numerous small scaly lesions. Characteristic feature about Pityriasis rosea, the scaling which is there is collarette of scales, and you see a Christmas tree appearance. Most common cause of contact allergic dermatitis. Yes, you're right. Nickel is the most common cause of contact allergic dermatitis that you see. Christmas tree distribution is right. Not poison ivy, but nickel. Rarest variety of pemphigus is nickel is the most common cause of contact allergic dermatitis. Rarest variety of pemphigus. Pemphigus vulgaris is commonest. Vulgaris means common. So yes, you are right. It is Pemphigus vegetans. This is the rarest variety of pemphigus. Okay. Multiple painful penile ulcers with painful buboes. What genital ulcer disease I'm talking about here? So if a patient presents with multiple painful penile ulcers with painful buboes. So buboes means lymph nodes. This is caused by which organism? Next question. Hair stays for maximum duration in which phase of hair cycle? And third, Ogog's pustule is seen in which condition and in which layer of skin? What are you? You guys have to revise your genital ulcer disease. It's not LGV. Yes, Dr. Vidhi, you're right. This is Haemophilus ducreyi. When you get a question like this, painful penile ulcers, multiple with painful buboes, I am definitely talking about chancroid. And chancroid is caused by Haemophilus ducreyi. Quickly, let me revise it for you. LGV does not present with ulcer. Ulcer is transient there, and you just get painful buboes. Donovanosis presents with beefy red granulomatous ulcer. It does not have lymph node involvement. Chancroid, multiple painful penile ulcers with buboes. Herpes also present with multiple painful lesions, but they are mostly vesicles and erosions. They are not ulcers. Syphilis, painless, single, indurated ulcer with lymph nodes which are not painful but shorty. Clear? It's not hard. Hard chancre is syphilis. This is soft chancre, chancroid. Okay? Next question. Hair stays maximum duration in anagen phase. You're right. So anagen phase is for 3 years. Telogen phase is for 3 weeks. Sorry, 3 months. Catagen is for 3 weeks. Right? Next question. Kogok's pustule is a feature of which condition? Where do you see Kogok's pustule? You have already answered that. Yes, in psoriasis. And which layer is Kogok's pustule in? So in psoriasis, you see collection of neutrophils. They are present in the stratum corneum, where they call as Moonrose microabscesses. And they are also present in stratum spinosum, where I call them Kogog's pustule. Yes, you can even see Malpighian layer. So Kogog's pustule is present in Malpighian layer. Moonrose microabscesses are seen in stratum corneum. They are both seen with psoriasis. Absolutely right. Castle's necklace is a classical clinical feature of what condition? Where do you see Castle's necklace? Which color kit will you use in patients with urethral discharge? I'll answer the last question because it's easy. Spongiosis is seen in stratum spinosum and commonly seen with acute eczemas. Acanthosis was with chronic eczema. Spongiosis is with acute eczemas. Answer the first two questions. Castle's necklace, absolutely right. It is pellagra. Not thiamine, please. It is because of niacinamide or vitamin B3. Thiamine is vitamin B1. So Castle's necklace is seen with pellagra, and that is caused by deficiency of niacinamide or vitamin B3. Yes, you use gray kit for urethral discharge. This is the most common kit which is asked for you. Gray kit, yes. Spongiosis, I've answered this, is seen in stratum spinosum. It appears as intercellular edema, and you see it in acute eczemas. Treatment of choice for tinea capitis. Second question, which primary or secondary skin lesion is never manifestation of secondary syphilis? And third, urticarial lesions are manifestation of which immunobullous disorders? So tinea capitis, the drug of choice is griseofulvin. You're right. It's the only condition now where we are using griseofulvin. Otherwise, we've shifted to allylamines and azoles for most of the tinea, but for capitis, we still use griseofulvin. Which primary or secondary skin lesion is never a manifestation of secondary syphilis? It is vesicle or bulla. You never see, secondary syphilis, you can see everything. You can see macule, papule, lichenoid, follicular lesions, but you do not ever see vesicles and bulla. However, with congenital syphilis, you can see vesicles and bulla. Right. Third question, urticarial lesions are manifestations of which immunobullous disorder? Do that. I asked which immunobullous disorder. Dermatographism can present with urticarial lesion. I am saying which immunobullous disorder you can see urticarial lesion. It is bullous pemphigoid. Bullous pemphigoid has a pre-urticarial phase, pre-bullous phase, where you do not see any bulla, but you just see urticarial lesions. So bullous pemphigoid is an immunobullous disorder where you see urticarial lesions. Quickly answer these next three questions. Which drug causes ichthyosis-like features and reddish discoloration of skin? So with which drug can you see ichthyosis as well as reddish discoloration of skin? Most common cause of plant dermatitis in India and ecthyma gangrenosum is caused by. We have to be quick so that we can cover most of the questions. Good. So this is clofazimine, quite clear with everyone. So I'll discuss orally till then. So yes, clofazimine is something which causes ichthyosis-like features and reddish discoloration of skin. Most common cause of plant dermatitis in India, I would say you should still go for Parthenium dermatitis. Don't say poison ivy, say Parthenium dermatitis, and the antigen there is sesquipteran lactone. Ecthyma gangrenosum is caused by, yes, please say Parthenium because still we follow Parthenium dermatitis. Ecthyma gangrenosum is caused by, quickly, yes, so ecthyma gangrenosum is caused by Pseudomonas. Ecthyma contagiosum is caused by pox virus. ecthyma infectiosum is caused by streptococcus. Please remember that, right? So ecthyma gangrenosum is Pseudomonas. Okay, Pseudomonas is the correct answer for gangrenosum, not pox. Pox virus causes ecthyma contagiosum. Drug used for unresponsive type 2 lepra reaction in an uncontrolled diabetic patient is. So if you have an uncontrolled diabetic patient with unresponsive type 2 lepra reaction, what will you give? Yes, thalidomide, it would be my drug of choice for uncontrolled diabetic patient. Otherwise, steroids are my drug of choice for type 2 lepra reaction, but in uncontrolled diabetic patient, I'll not give steroids, so I'll give thalidomide here. Sheets of erythema with islands of normal skin is a feature of pityriasis rubra pilaris. I'm answering that for you. PRP is a papillosquamous disorder which presents with sheets of erythema with islands of normal skin. Where do you use vismodegib? Vismodegib is used in the treatment of basal cell carcinoma. Yes, you see nutmeg crater papules in PRP, you see PRP sandals, and in yes, absolutely right. So vismodegib is a treatment that you use in invasive advanced BCC or patients who do not want to go for surgical treatment. What is the best treatment for telogen effluvium? Treatment of choice for psoriasis in HIV positive patients. For dye spots, we've already discussed. They are ectopic sebaceous gland. Yes, so they are hedgehog pathway inhibitor. Absolutely right. Vismodegib is a hedgehog pathway inhibitor. So for dye spots, this we have already discussed. They are ectopic sebaceous glands. What about other two questions? So best treatment for telogen effluvium is biotin plus supplements. You do not require any treatment. You just need to counsel the patient and give them biotin and supplements. No minoxidil needed because telogen effluvium happens because of some reason which is gone. Your hair would recover again. It's just a hair cycle disturbance. Biotin. What is the treatment of choice for psoriasis in HIV positive patients? If a patient is HIV positive, you do not use methotrexate, you do not use other drugs, you only use acitretin here because it is not an immunosuppressant. So acitretin is my drug of choice in patients of psoriasis who are HIV positive. Okay. Multilocular painful buboes, this we have discussed. So if you have multilocular painful buboes, it is lymphogranuloma venereum. So here the answer would be LGV. How can you differentiate between nevus anemicus and nevus depigmentosus? Yes, now you are all right. It is LGV, multilocular painful buboes with discharging sinuses. Test to differentiate between nevus anemicus and nevus depigmentosus. Slide test, it's called as dioscopy. The test is called as dioscopy. Next question is easy. Fishnet pattern of immunofluorescence is something that you see in Pemphigus group of disorders. So I'm not asking you this. This is easy. So here the answer is dioscopy. Dioscopy helps to differentiate between nevus anemicus and nevus depigmentosus. Great. Okay, and ichthyosis, which mainly presents on extensors and with associated with atopy. This is ichthyosis vulgaris. Right, the commonest type of ichthyosis mainly presents on extensors and is associated with atopy. What is hereditary angioedema caused by? Deficiency of what? And what is the classical histopath feature that you see in molluscum contagiosum? Right, hereditary angioedema is caused by deficiency of C1 inhibitor. It is mainly a bradykinin-mediated disorder where you see angioedema, you can see recurrent colicky pains, and this is caused by deficiency of C1 inhibitor. The classical histopath finding in molluscum contagiosum. Quickly, this is so easy. Yes, you see Anderson, Peterson bodies or HP bodies, which are intracytoplasmic eosinophilic inclusion bodies. This is what you see in molluscum contagiosum. Cradle cap is a form of which dermatosis? I'll tell you this, you answer me next too. Seborrheic capitis in children, especially infants, presents with cradle cap. So you have thick, scaly lesions on the scalp in infants. This is called as cradle cap, and it is a part of seborrheic capitis or malassezia infection. Not favus. Favus presents with scutula, not cradle cap. Favus presents with cup-shaped crust, which is called as scutula. Cradle cap is seborrheic dermatitis in infants. The most effective drug against M. leprae. So we use three drugs, rifampicin, dapsone, and clofazimine. Which do you think is the most effective against M. leprae? Yes, it is rifampicin, not dapsone. You know, even one dose of rifampicin kills 99% of viable lepra bacilli. So my most effective drug is rifampicin. But I gave a combination of drugs to prevent resistance and to kill those 1%. Burrows and scabies are seen in stratum corneum. This is right. These burrows can extend up to stratum malpighi, but if they ask you which layer of skin do you see it in, it is stratum corneum. Reedley-Joplin classification does not include what types of leprosy? So I'll quickly answer here. It does not involve indeterminate and pure neuritic Hansen. These are more endemic to India. So this is not included in Reedley-Joplin classification. Yes. Most common causative organism for tinea capitis is indeterminate. This is good. Answer the next two questions. Most common causative organism for tinea capitis is, now it is T. tonsurans. Earlier it was Microsporum canis. Now the most common causative organism is T. tonsurans. Not M for first. Good, you deleted it. That's okay. Yes, it is Trichophyton tonsurans. Chancre redux refers to, you see it in which stage of syphilis? So this is seen in relapsing syphilis, and it refers to occurrence of lesion of relapsing syphilis at the site of chancre, right? So chancre redux is when you see a lesion of relapsing syphilis on the site of chancre. Chancre pseudo chancre redux is something that is seen in tertiary syphilis. It is gamma occurring at the site of chancre. Yes, good. Oral steroids are indicated in which type of psoriasis? In pustular psoriasis of pregnancy, which is also called as, yes, impetigo herpetiformis. You do not see it in erythrodermic psoriasis. Please remember that. Oral steroids are only used for pustular psoriasis of pregnancy or impetigo herpetiformis. Good. What is seen at the periphery of alopecia areata patch? So what is one thing that you see clinically in alopecia areata patch? An inheritance of incontinentia pigmenti is. Yes, exclamation mark here. Quite easy. Inheritance of incontinentia pigmenti. It is X-linked dominant. X-linked dominant disorders are rare, and incontinentia pigmenti is X-linked dominant. Which laser do you use to treat dermal melanocytic nevi? These are pigment lasers. Specifically, you use alexandrite, ruby, or Nd:YAG laser. Where do you see asteroid bodies? Yes, asteroid bodies are commonly seen in sporotrichosis. This is another very important topic that is asked. What is the treatment of choice for mycosis fungoides? Good, great. Treatment of choice for mycosis fungoides is electron beam therapy. Sorry, I'm answering you because I think there is a time which is short and I want to cover all the questions. Not rituximab, not PUVA. It is electron beam therapy, also referred to as total skin electron beam therapy. This is the treatment of choice for mycosis fungoides. Hypopigmentation in pityriasis versicolor is due to. So this is something that you would be knowing. So it is due to production of carboxylic acids. So due to production of carboxylic acids, there is hypopigmentation in pityriasis versicolor. Ash leaf macule is a feature of. This I'll answer. First sensation to be lost in leprosy is temperature. Ash leaf macule is a feature of tuberous sclerosis. You're right. Tuberous sclerosis, you see ash leaf macules, you see various hematomas. First sensation to be lost in leprosy is loss of temperature sensation. What is the wavelength of narrowband UVB therapy? Yes, cold goes first and then hot, but mostly you'll be asked about temperature. Wavelength of narrowband UVB therapy. Good. 311 to 313 nanometer is the wavelength of UVB therapy. Clue cells form part of which criteria and are used to diagnose which conditions? This is easy. I'll tell you this. The lines in skin which follow lines of embryonic migration are called as Blaschko's lines. Yes, so they're used for bacterial vaginosis and the criteria is called as Amsel's criteria. Lines which follow lines of embryonic migration are called as Blaschko's lines. Podophyllin is used for treatment of, so this is used for genital warts. Itch is a disease. Incontinentia pigmenti is something that would follow Blaschko's lines. Yes, they're used for genital warts. Itch is a disease is true for which disease? For which disease do you say that itch is a disease? Mucus patches are manifestations of secondary syphilis. Itch is a disease is true for atopic dermatitis. So for atopic dermatitis, it is also called that itch is a disease. Not scabies, not fungal infection. It is atopic dermatitis. Okay? Because it's mainly itching which is causing that. In pure neuritic Hansen, you do nerve biopsy from ulnar nerve. Or you can also say sural nerve if ulnar nerve is not there in the option. Rhinophyma is granulomatous rosacea. So a form of rosacea where you see potato nose is rhinophyma or granulomatous rosacea. Yes. Sclerotic bodies. Oh, I'm so sorry. So sorry. I said ulnar nerve. You never do a biopsy from ulnar nerve. Sorry. So you do it from, I'm so sorry. It is superficial cutaneous branch of radial nerve. Okay? Or radial cutaneous nerve. I'm so sorry. I think I'm also getting tense. So don't worry, you've learned by heart and you do very well. Sclerotic bodies are sporotrichosis. You guys really know very well. Sorry, again, I think I'll concentrate here. I'm looking at messages. Sclerotic bodies are penny-shaped bodies or copper penny bodies which are seen with chromoblastomycosis, not with sporotrichosis. In sporotrichosis, you see asteroid bodies. Sclerotic bodies are part of chronoblastomycosis. Yes, you're right. I'm so sorry, everyone. You're right. One melanocyte transfers melanosome to how many keratinocytes around it? This is 36. So one melanocyte transfers keratinocytes to 36 keratinocytes around it. And this is called as epidermal melanin unit. Where do you see circinate balanitis? Where do you see circinate balanitis? And geographical lesions are seen in which spectrum of leprosy? So this is seen in BB Hansen. Map-like configuration or geographical configuration are seen in BB Hansen. Circinate balanitis is a feature of reactive arthritis, also referred to as Retter's disease. We also see keratoderma blennorhechicum there. Pemphigus is caused by, you all know this, T-Conleni. Sweet syndrome shows presence of which cells on blood smear and histopathology. It is a neutrophilic dermatosis, so you will see neutrophils here. Last question, geometric shallow pits are a feature of. Geometric shallow pits are a feature of. Quickly, this one you would answer. Yes, it is sweet syndrome is acute neutrophilic dermatosis, so you see neutrophils there. No, not pitted keratolysis. Geometric shallow pits on nails. I think I'll be more specific here. That will make it easier. So if there are geometrical shallow pits on nails, they are feature of alopecia areata. With psoriasis, you see deep, random, irregular pits. Yes, I'm so sorry. I think you get confused. I was talking about pits on nails. So the geometric shallow pits on nails is seen with alopecia areata, right? So that was a quick recap of dermatology. Some 100 one-liners in dermatology, covering almost whatever I could of dermatology in this 1 hour, 20 minutes. So all the best for your exams, and I'm sure you were answering pretty well. So you know most of dermatology. Believe me, it's not easy to answer one-liners when you do not have the options. I can totally understand that. So I can understand the confusion at times, but you guys did great. And please keep up your confidence, keep revising, and you would come out with flying colors. Okay, take care. Thank you so much. And I'll end my session here.